This was an oral presentation. So as you probably know, we are increasingly offering allogeneic transplantation to older adults. In fact, in 2021 in the United States, 56% of all transplants were in recipients aged 50 years or older. And more recently, based on the BMT-CTN 1703 trial, post-transplant cyclophosphamide has been established as an accepted GvHD prophylaxis in the setting of reduced intensity conditioning regimens. And clinicians are often faced with the question of choosing either a young alternative donor versus an older age to match sibling donor, given the strong correlation in patient age between siblings and patients. And thus far, I think, the data regarding the impact of donor age across the donor types is somewhat conflicting, and typically those studies have excluded patients who have received PTCy-based GvHD prophylaxis, which is why we embarked on a retrospective analysis using CIBMTR registry data to assess the impact of donor age across donor types limited to PTCy-based GvHD prophylaxis. And we hypothesized that using younger alternative donors may be associated with improved outcomes compared to their older-aged matched sibling donor counterparts. And we defined young alternative donors as either HLA-8 MUDs, haploidentical donors, or mismatched unrelated donors. And the donor age we selected to define young was less than or equal to 35 years of age. And this was compared to outcomes in older-aged matched sibling donors with the donor age was 50 years or older. Regarding the inclusion criteria for this registry analysis, we included all transplant recipients aged 50 years or older with a diagnosis of either AML, ALL, or MDS, and transplanted between 2014 to 2021 with either the older-aged matched sibling donor aged over 50 years versus a young MUD, haplo, or mismatched unrelated donor with a donor age of less than or equal to 35 years. All patients, as I said, received PTCy-based GvHD prophylaxis. And we have over 3,700 plus patients in this registry analysis. Regarding the mean age of the transplant recipients within the entire cohort, it was about 63 years of age. Most patients, or the majority of patients, did have a HCTCI score of 3 or higher. Most had a diagnosis of AML, followed then by MDS and then ALL. I guess the more important question is what were the donor ages, and the mean donor age in the older-aged matched sibling donor cohort was 60 years compared to about 26 to 28 years for the young alternative donors, so the MUD, haplo, and mismatched unrelated donors. Majority of patients received either reduced intensity or non-myeloablative conditioning, and the median follow-up was over 36 months in the entire cohort. And I guess the primary endpoint was overall survival, and what we found in multivariable analysis was that using a young matched unrelated donor compared to an older-aged matched sibling donor had an improved overall survival with a hazard ratio of 1.2, and there was an 8% difference in the 5-year adjusted probability of overall survival, with improvement when the young MUD compared to the older-aged matched sibling donor cohort. It did not reach statistical significance based on a Bonferini adjusted p-value to correct for multiple comparisons. But nonetheless, I think this was quite a significant finding. There were no other significant differences with the use of either a young mismatched unrelated donor or a young haploidentical donor compared to their older-aged matched sibling donor counterpart. And between the young alternative donors, we did find a significantly higher overall survival with the use of a young MUD compared to a young haploidentical donor. And the reason for the improved overall survival in the young MUD cohort compared to the other counterparts was really seemed to be improved disease-free survival due to a reduced risk of relapse. In the haploidentical cohort, there was a signal for perhaps slightly higher incidence of non-relapse mortality as well. So I would say that the concluding findings of this work is that in patients aged 50 years or older and who receive PTCy-based GvHD prophylaxis and have a diagnosis of either acute leukemia or myelodysplastic syndromes, these data would suggest preferential consideration of a young, matched unrelated donor aged 35 years or younger rather than an older aged matched sibling donor or young haploidentical donor.